Hello, my name is Dr. Toby. I'm the Chief Medical Officer for Savas Health, and I want to utilize this brief presentation to make the case for what we call unitized transdisciplinary care delivery. I'm going to outline the problem that we try to solve with this, and then want to walk you through the rationale why we ended up creating this unitized transdisciplinary care model. The problem, most of you are probably very familiar with at this point, are these two main issues that we are dealing with. One is the huge burden of chronic pain that a lot of us individually have experienced with throughout our life. But besides this being a big individual burden, it also is a huge burden for society at large. And the second problem that is very concerning over the last few years, which is the opioid crisis that has been spun out of this. And I think the connection lies in a very simple truth that complex pain has different drivers. We understand this as a problem with biological, psychological, and social components. And what we've done in the past is probably overemphasize the biological aspect and utilizing the tool being medication, specifically the opioids, to try to approach this broader problem. A good analogy to that is if you're looking at something else which is complex, let's say building a house, it probably requires a lot of different tools used at different times and frequencies to achieve the goal. If you were to imagine to use a hammer not only to hit in nails, but also to try to paint the building, you can see that even a good intention could cause damage. So from a medical standpoint, we knew that this biopsychosocial problem is best met by pulling in different disciplines that have expertise in each one of the areas and creating what is called a multidisciplinary approach to it. And there's a big body of literature supporting that. And what we've seen recently is that the governing bodies that are in charge of the healthcare delivery seem to adopt that model and thinking process. You can see that we had a congressional mandated task force, and the emphasis from that was that the treatment of chronic pain must be changed to a patient-centered, population-based, integrated treatment. They were fairly specific. They pointed out in the summary statement that they found the efficacy of a coordinated, integrated approach, and they recommend a biopsychosocial, individualized, multidisciplinary, coordinated but compassionate care as the ideal solution to treating pain. And what we did was precisely doing that in our clinics, starting by combining the specialties available in a more, traditional multidisciplinary fashion. We pull in medical providers in the medical department, behavioral providers addressing the psychological issues, physical reconditioning to work on the body, and then integrating more traditional treatment services. What we found were that we reached several limitations rather quickly. One limitation was purely logistics. When you try to scale a model like this, just if you were to think about the different scheduling and rescheduling that's involved, if you do that on a larger scale with all of these services, is a big issue. We also found limitation from our patients' compliance or even ability to work under a model like this. If you think about patients having to organize things like transportation, taking off of work, organizing childcare, and they now have to do that multiple times a week, ideally, to see different services, it becomes a huge issue. On the provider side, the providers need to be able to communicate in real time around their plans. So the whole limitations combined made it very difficult to scale. So how did we change that? The first adjustment that we wanted to do was really move from a multidisciplinary to a transdisciplinary approach. And I'm going to use these little fruit platters here to walk you through that in a I think, very easy to follow way. Although multidisciplinary, interdisciplinary, and transdisciplinary often are used interchangeable, and you might argue that differences are only nuances, we've seen that the impact of these differences is immense. A multidisciplinary approach is best described as a consecutive delivery of services. So you either take a piece of banana first, followed by a piece of peach, and then an apple. And the analogy to that would be you see the medical doctor, let's say at 8 o'clock, physical reconditioning at 10, and then the psychologist is 1 o'clock. If you move from this multidisciplinary into an interdisciplinary, where the delivery of care, or in this case, the tasting of the different components of the service are parallel delivery, reflected here in the bowl of a fruit salad. You can imagine that the experience, the taste experience from taking a bite out of a fruit salad is much different because you have the flavors mixing, and you can see the same thing in the medical environment. What is really important is what we've done as the next step is just taking the fruits that the patients need, put them in a blender and make a smoothie. Because ultimately, if the patient needs vitamin C, it doesn't really matter if that vitamin C came from an apple, banana, or peach. It's just important that the right amount of vitamin C is in that smoothie. So you are breaking the boundaries of the sources. And we did the same by breaking the boundaries of the disciplines and really have this integrated transdisciplinary approach. What transdisciplinary care does is it ensures the patients receive their appropriate services and each team member can maximize the impact. And we didn't come up with that, besides chronic pain, it has been shown to be very effective in other complex diseases, including neurological disorders and endocrinologic disorders like diabetes, for example. So the big question that lends itself is if we agree from a clinical and a government side that this is the best approach to choose, why aren't we doing it? And this is a rhetorical question. Obviously, there's certain hurdles that you have to overcome to be able to do this in a scalable fashion. The first one is the notion that you can't just take a transdisciplinary approach that works for an individual patient or an individual clinic and scale it largely. You have to make adjustments. Second thing, and along those lines, the collaboration that needs to happen among the team as well as the service requirements that really each of the population needs have to be taken into consideration on this large scale. One of the consequences from that we found is that you must shift your focus from thinking about having to fit the patient on a provider schedule and turning that around, having provider schedules fit the patient's needs. And lastly, this is a newer concept, so you really need to make sure that you have this transdisciplinary setting in a secured environment where you have little to no crossover to the usual objectives. If you look at the implementation that we wanted to achieve with that, we wanted to make sure that we had creating a patient-centered system where the patient is surrounded by their peers. You bring in the providers that are required to deliver the care. You create the schedules around that to allow for the patients to have a very simple and easy to follow way of doing that. You have to make sure that you put the patient's goal at the center of the treatment plans. You then have to measure the outcomes. Do we achieve what we are trying to achieve? And then you have to work with the different services available and maybe adjust those to achieve the outcomes you're looking for. A little more implementation detail of how that translates into real life is that if you look at your populations, you got to define what kind of services and how often does my population need them. Then you have to create an environment where you schedule the providers and support personnel to allow them to deliver these services. You then should go and ideally create an environment from the facilities that allow an easy flow for these services and service frequencies to happen. And then you have to build an operational support around that is thinking transdisciplinary, understands the concepts, and allows that to function quickly and easily. The last concept I want to introduce here is the concept of a unit, which we developed to solve some of the limitations I outlined earlier. So what a unit really is that we combined a group of patients to come in at the same time with a group of providers. We identify the needs of the group of patients, both long-term, but also right there at that moment. And we treat the patients that showed up with the providers that are available, while still discussing the patients that are supposed to be part of this group that for, let's say, no short for what various reasons, still discuss them among the team members and be able to communicate and carry out the treatment plans. So it really allowed us to optimize that. And one thing I want to point out there, it allowed us to create an environment which I call a zero waste environment. Just to illustrate that, let's say that we have 8 patients in the unit and a provider has 2 hours in the unit. So there will be 8 patients divided by 2 hours, 15-minute slots. Each one of these patients should be seen individually. If from the 8 patients scheduled, only 6 show up, instead of having a provider having 2 15-minute slots that are empty because of the no-shows where you waste their time, you just adjust the schedule. So if instead of having 8 patients for 2 hours, you have 6 patients for 2 hours, you just adjust the appointment times from being 15-minute slots to a 20-minute slot. This way, you optimize the provider time with the needs of the patients. You have the consistent group of patients that allows for the peer support. Patients really encourage each other, see each other's successes, and become part of the treatment themselves. It allows you, this unit, to have individual scheduling in parallel with group scheduling. The advantage of group scheduling is that it's very easy to adjust the size of a group. Typically, if you have 3, 5, or 7 people sitting in a group, it doesn't make such a big difference between having 3, 5, or 7 patients that you squeeze into an individual appointment. And lastly, using these units, typically between 1 and 2.5 hours in length, allows for very easy scheduling and planning for the patients too. They just get assigned their unit. Let's say it's a Tuesday afternoon at 2 o'clock when they typically have time. So you put them in a Tuesday afternoon, 2 o'clock unit, and they come either once a week, once a month, or somewhere in between, but they can always stick to that time slot, which makes a lot of these logistic issues go away. So that basically concludes my brief overview. I hope that I could point out the rationale why we created this unitized transdisciplinary care. And I'm proud to say that we've experienced a lot of patient improvements, cost savings, and created an environment that both the providers and patients really like to be in. Thanks for your attention.
The journey began when I was 16 years old and found out that I had Bertolotti syndrome. And 5 years later, I had my first spinal fusion.
A semi pulled out in front of us, and I went through the windshield and landed on the hood of the semi. And I fractured all the ribs on my left side and my lumbar, and that's how my pain started.
I was carrying some plastic sacks of groceries on a soft, sandy ground, and for some reason, something pulled out. By the next morning, I was on the ground, and I was in a difficult situation.
My uterus was shredded. My tubes were smashed flat and stuck onto my uterus. My ovaries were bruised beyond anybody being able to get anything out of them, so he had to do a complete hysterectomy. And he really couldn't explain to me what she did. Basically, he said it looked like she set off a bomb inside your belly and just closed you up and sent you home.
So the chronic pain has been going on for probably 30 years. And until I got here, I didn't feel I had any hope.
I sat down, and there was a semicircle of medical professionals all looking at me, prepared to help. I wept. My first reaction was I wept. I couldn't contain myself. I mean, I'm ready to weep just, in recollection of that moment.
And then I was laying there, and after having an acupuncture, and I just went to sleep, and I woke up and there was no pain. And I started crying. Because
how long had it been?
17 years.
When you walk in the doors, you don't have to prove that you're disabled. Everybody in that room knows you're disabled, and they have it too. So sometimes you just look across the room, you feel like crying, and somebody smiles at you, and then all these professionals here, that's all they want. That's all they want is for us to learn how to put it in perspective so that it's not the first thing you think of when your feet hit the floor. And My life has changed so much. And now with all the new treatments, I can't wait to come in here.
Yeah, if I did come here, I would probably ended it because I was tired of it, you know. So many years with being in pain and all the medication and all that, it helps a little bit, but the pain's always there, you know. And, it's not there all the time now, you know. It goes away now.
For you to deny that you're wondering whether or not life is something worth living, well, those are big, dark questions that really come up. So, I said earlier, my wife saved me by finding this place, and by virtue of her actions, the Desert Clinic saved me. It gave me a reason to go on. It gave me all these tools. And I'm just grateful. I'm ever grateful for it.